Hello, my name is Matt Strelo from Stanford University. In this lecture, we're going to talk about shock. Shock is a critical aspect of managing and evaluating patients for healthcare providers, as it is the end stage of many disease processes, and we see these patients frequently, both in the emergency department, the hospital, and the ICU, and you will occasionally see these patients in the clinic as well. So let's get started with a case of a 70-year-old woman who comes in with fever, complaining of back pain. We're going to take our emergency medicine approach to this potentially sick patient, where we're going to evaluate, think, and act simultaneously. And so as we get started with our evaluation or our initial assessment, we approach the patient and we see her general appearance and level of consciousness. She's an elderly patient sitting semi-upright in bed, and she does appear alert to her surroundings as you walk in, so she's an A on the AVPU scale. We evaluate her airway by introducing ourselves and asking her name, and she states that her name is Kathy, so her airway appears clear. We look at her breathing and we listen to her as she speaks. Her breathing is rapid, but she's able to speak in full sentences and doesn't seem in significant distress. And we look at her circulation. And so I generally do this when I'm shaking the patient's hand. I check their radial pulse. And on her radial pulse evaluation, you note that her radial pulse is rapid and a little bit weak though, and it's not easy to palpate. At this point, we've gone through our general appearance and ABCs, and we want to get a full set of vital signs. This patient's vital signs show tachycardia with a heart rate of 120, a respiratory rate that is fast at 30, the blood pressure is low at 90/50, oxygen saturation is normal at 98% on room air, and she does have a fever with a temperature of 38.9 degrees centigrade. So as we're doing this patient's initial assessment, we're thinking about this patient. And the question we're asking ourselves, as we are in all patients, is this patient sick? The answer clearly here with the tachycardia, the tachypnea, and the weak pulse and the low blood pressure is yes, this patient is sick, so we are going to act. And on our early actions or immediate interventions, we're going to position this patient in a position of comfort, make sure that we apply oxygen to the patient, put the patient on a cardiac monitor to check the rhythm, and then establish an IV. And in this patient with some signs of shock, we're going to initiate IV fluids. Be careful when giving fluids to these patients that are sick. I frequently see people that don't practice in emergency settings or in ICU settings, starting by giving patients a fluid rate, such as 100 mLs of normal saline an hour. And that rate is too slow. If you're worried about giving the patient too many fluids, and over-resuscitating them, then you're going to want to use smaller boluses, but you still want to use a bolus format and just give them very rapidly and do frequent reassessments to look for volume overload. For example, in a patient who I know has a history of heart failure, I might use a 250 cc bolus of normal saline or lactated ringers and give that over a short period of time, 5 or 10 minutes, and then reassess the patient and keep giving frequent boluses as I'm checking the patient. In a patient with no concerns of volume overload or heart failure, I'm going to start with a 500 to 1 liter bolus oftentimes. So in our emergency medicine approach to this patient, we've determined that she's an elderly female with a fever. She's got some tachycardia and a weak pulse and a fast respiratory rate. We've decided that she is sick, and we've done our early actions and interventions. And the other question we're going to ask ourselves is this patient in shock? Well, in order to decide if the patient's in shock, we need a clear definition of shock. Unfortunately, it's been a challenge for many centuries now to define shock, but our current definition of shock is that shock is not enough blood flow to meet the metabolic demands or needs of the tissues and cells. Something that's really important to remember is that shock is not a low blood pressure. A low blood pressure can be a sign of shock, but patients can clearly be in shock when their blood pressure is not low, or at least low based on what we generally use as a cutoff. Let me give you an example of that. Here are two patients. Ask yourself, which patient is in shock? The first patient is a patient with chronic liver failure who feels well, who on routine evaluation has a blood pressure of 85/45. The second patient has pneumonia, acidosis, altered mental status, and their blood pressure is 100/50. Well, if you're using a traditional cutoff for a systolic blood pressure of less than 90 for shock, you would probably say patient 1, but clearly that's incorrect. Clearly patient 2 is the patient in shock, and patient 1 is at their baseline. So blood pressure alone is not our definition of shock. Patients typically move through different stages of shock as they get more ill. And they'll start in compensated shock, where the body is able to keep the blood pressure up by causing vasoconstriction peripherally, increasing the heart rate and cardiac output. But over time, our compensatory mechanisms will fail, and the patient may move into uncompensated shock. Now, patients can move back and forth between compensated and uncompensated shock, either through interventions that we may be performing or through the body's own efforts to compensate for their shock. But as the patient gets even more ill and they move through uncompensated shock, they may end up in irreversible shock. And this is the end stage. This is the point at which no matter what you do, that patient's life is going to end, regardless of our interventions. So the take-home point, the most important thing that you need to remember when evaluating and managing patients in shock is this: that early recognition of shock and early intervention are the most important factors in saving a patient's life. If you can identify the shock early and intervene appropriately before there's hypoperfusion of the organs and there starts to be multiple organ dysfunction syndrome and the patient starts to have major other abnormalities, you have the best chance of saving that patient. So what are the early signs of shock that we want to be looking for? Well, I've listed a few here. Some of our early warning signs would be tachypnea, tachycardia, anxiety, restlessness, and also feeling the skin and looking at the skin. Is it pale? Is it cool? Now, late signs of shock are what we're often taught, though, looking at like a low blood pressure, which we've already talked about, or other signs of end organ dysfunction, where the end organs are already starting to not work, such as decreased urine output, altered mental status, and acidosis, or other organ failure. There's a few things that I like to make sure that I examine in patients when I think they're in shock, okay? These are shock index, poor skin perfusion, urine output, and I like to look at their mental status as well and check and see if they're at their baseline mental status or if they're altered. Let's look at each of these individual. What is the shock index? The shock index is the heart rate divided by the systolic blood pressure. Now, traditionally, we've looked at the heart rate separately from the blood pressure, but both of these look at the cardiovascular system. And the shock index is an effort to look at both of these mechanisms together to try to determine with more sensitivity if there's cardiovascular dysfunction or the body is under a lot of stress trying to maintain perfusion. So a typical heart rate, let's say, is 60 for an adult and a systolic blood pressure of, let's say, 120. So a typical healthy shock index would be 60 divided by 120, or 0.5. Now, that's what we find in most patients, where a normal shock index is 0.5 to 0.7. Anything greater than, let's say, 0.8 or 0.9 is considered significantly abnormal. The shock index has been shown in both medical and in trauma patients to be more sensitive than either heart rate or blood pressure alone for detecting early shock. It's still not near 100% sensitive, but it does move the needle from around 20 to 30% using heart rate or blood pressure individually to 50 to 60% sensitive when using them together. Quick quiz on shock index. A patient's vital signs are 140 heart rate, blood pressure of 100/40, respiratory rate of 20, and a saturation of 98%. What is this patient's shock index? So if you've thought about it, we know that it's heart rate divided by systolic blood pressure, so it's 140 divided by 100. Now I know physicians and healthcare providers don't like math, but even we can do this one. So the answer is C, 1.4. And we said that anything greater than 0.8 or 0.9 is significantly abnormal and concerning for cardiovascular dysfunction or distress. So this would be a patient that we would think their shock index points to a sick patient who is in early shock. The second thing I mentioned was looking at skin perfusion. And I like to check the capillary refill, okay? And typically in adults we use a cutoff of 2 seconds for capillary refill. But there has been a nice study done a few years ago which looked and used a cutoff of greater than 4.5 seconds for capillary refill. And they also examined whether the extremities felt cool to the touch. It was an interesting study where they took patients in the emergency department in shock. They had a senior physician both check the capillary refill and check the extremities temperature. And if they felt that the extremities were either cool to the touch or the capillary refill was greater than 4.5 seconds, they wrote that down, and then they resuscitated the patients who were obviously in shock. And following resuscitation, after the vital signs had improved and they no longer appeared to be in shock, they had the same physician then evaluate the patients again, checking both the capillary refill and the skin for whether it was cool or not in the extremities. And despite the fact that the patient's vital signs looked better, if the patient had an abnormal skin perfusion, so a prolonged capillary refill, or the extremities were cool to the touch, those patients still had a higher rate of organ failure and a higher chance of dying. So what this shows us is that we can follow skin perfusion both early and as we resuscitate as a marker of whether that patient is adequately resuscitated. So in a patient that comes in, if their skin is cool to the touch in the extremities and I resuscitate them, and their skin remains cool, even if their vital signs look better, I'm going to continue my resuscitation aggressively with that patient. Because what I've found, what others have found, is that patients tend to warm up and their capillary refill improves. Another thing we typically use in hospitals, but we frequently don't use early on, is watching the urine output. And urine output is a really good marker of renal perfusion. And although we can't use the initial volume of urine we get out when a Foley catheter or a catheter is placed in a patient, when we're in the emergency setting, because we don't know if the patient urinated recently or if it's been many hours, so we don't know how much urine was in the bladder and if that urine is new or old. But if we put the catheter in early and start monitoring urine output in sick patients, and we watch it for over 30 minutes, okay, what we want to see is during active resuscitation, we want to see that patient's making greater than 1 ml per kilo per hour, which shows that we're being successful with our resuscitation and that those kidneys are well perfused. Now, if the patient is in that 0.5 to 1 ml per kilo per hour, that may be normal in a patient who's been in the hospital for a while and is not in shock. But in a patient who's in shock that we're actively resuscitating, those patients, we would still consider that a reduced amount of urine output. And severely reduced would be anybody less than 0.5 mLs per kilo per hour. In those patients, they obviously need ongoing aggressive resuscitation. And finally, I like to make sure I check altered mental status. And I think we give this some lip service, but I'm not sure we really check it thoroughly. And what I mean by that is I frequently see healthcare providers see an elderly patient. The patient's a little bit kind of a poor responder, a little slow, maybe a little bit confused, and the healthcare provider attributes that to like chronic dementia or old age, and doesn't really delve into whether the patient's mental status is off their baseline. And frequently what happens is we find out by talking to family members that the patient is more confused or off their baseline, and that it's not chronic dementia, but it's actually hypoperfusion from shock. Following a little bit of resuscitation, the patient's mental status improves, and we've confirmed that. So be careful with that. In summary, early recognition of shock and early intervention appropriately is key to saving these patients' lives. Patients may be in shock even if the BP is not low, right? Compensated shock. And during evaluation of patients, make sure that you've checked the shock index, their skin perfusion, be monitoring their urine output closely, and make sure you've checked their mental status in comparison to their baseline and continue to follow that over time. Thank you.